Hello friends, good afternoon. Welcome to the test and discussion. So we're going to start with the first question. All right. Let's understand here, what did you pick? What is the most appropriate next step in her management? They are asking you. All right. So when you read through such long stem questions, it is always a good idea, to first see what they are asking you. You read the first line. There is a 30-year-old female, 28 weeks of gestation. She presents with 75-gram OGT report, and the report is given to you. So this is a pregnancy for diabetes. This is a question on diabetes in pregnancy, right? Then they're asking you what is the most appropriate next step in her management. Now you read the four options: continue dietary modification and exercise, insulin, glibenclamide, metformin. So these are your options. And now when you read the options, you understand what they are trying to ask you. So now when you read the question, you will know that you have to choose from among these options, right? Like for example, going ahead only, I can rule out that glibenclamide and metformin are not likely going to be the treatment strategies. I mean, I'm not going to prefer glibenclamide and metformin, right? Oral hypoglycemic agents, they are not going to be the first line or most appropriate next step in the management straight away, right? B is the correct answer. So we have 75-gram OGTT and 2-hour postprandial blood glucose level of 170, right? So this is more than or equal to 140, right? So the diagnosis is GDM and the diagnosis has been made. Okay, diagnosis is GDM, and that is why she was initially managed with medical nutrition therapy and exercise. After 2-week follow-up, her fasting blood sugar is 120. You don't need to I mean, 120 is definitely high. They are not going to give you, very borderline values, right? So what you need to understand is when you say control, when you say control during pregnancy, control means what? Control means fasting blood sugar should be below 95 and your 2-hour post-meal values should be less than 140. Sorry, 2-hour value should be less than 120. Okay. So basically this is the level of control we are talking about. So she is not controlled even on medical nutrition and therapy and exercise. Therefore now we have to start her on insulin. Therefore, now we have to start her on insulin. So this is how you will attempt this question, right? So let's suppose if the woman is diagnosed with overt values in the overt range values, then what is the treatment of choice? That means when she is diagnosed, at that time only, her sugar values are very deranged. They are in the overt range to begin with. As in when she was diagnosed with overt range values. Then what is the treatment of choice? Yes, then we have to start insulin straight away. That doesn't mean that medical nutritional therapy and exercise will not be advised. Obviously, the medical nutritional therapy and everything will be advised, that is definite, but we have to start insulin, in that patient. Okay. Now also remember that glibenclamide, which is glyburide, okay, and metformin, these are considered now safe. These are considered safe in pregnancy. These two drugs are also considered safe in pregnancy, but they are not the first line drugs, especially when sugars are not getting controlled and especially when sugars are in the overt range. So they are considered safe, yes, in GDM patients. In GDM patients, they are considered safe, but they are not going to be the most appropriate or the first line therapy agent. So keep that in mind also. Now moving on, let me just highlight one more pointer for you, which could be a potential question in your exams, but for that I need to give you a little bit more perspective, okay? So INI-CET has a tendency of asking questions from these values, okay, because AIIMS and Delhi, we follow these values. So you need to remember them particularly for INI-CET, okay? Fasting more than equal to 92 but less than 126 and 2-hour more than or equal to 153 but less than 200. If any one is abnormal, your diagnosis is GDM. Okay, remember this. Now, fasting more than or equal to 126 or 2-hour more than 200 or HbA1c more than 6.5% or random which is more than 200 plus symptoms. This is how you diagnose diabetes even outside of pregnancy. So, you don't have to remember any other pregnancy related range. This is the diagnosis of diabetes even outside of pregnancy. And when we have such grossly, overt range values, we will say this is likely overt diabetes mellitus. Likely overt diabetes mellitus, because many times what happens is pregnant women are getting themselves tested for blood sugars or getting themselves screened for the first time in pregnancy only. So many times it happens that we pick up overt diabetes mellitus in a pregnant woman because we're happening to test her in pregnancy. Now, if such values are seen in the first trimester, then your diagnosis is going to be definitely overt diabetes mellitus. Then your diagnosis is definitely going to be overt diabetes mellitus. Now, if such values are seen later, seen later, just get a general idea. They're not going to ask you this, but understand the logic behind it. If you're seeing such values in the first trimester, then so definitely it is overt diabetes mellitus. That means that periconceptional values must have also been abnormal. But if you see later, then we are not very sure whether it is overt diabetes or it is GDM. It's likely going to turn out to be overt diabetes mellitus, but we have to check. We have to check and confirm 6 weeks postpartum. Okay, 6 weeks postpartum. Why? Because when you have GDM, the sugar levels will become normal. Sugar levels will become normal within 6 weeks postpartum. And if they don't become normal, then we label it as overt diabetes mellitus. So, overt diabetes mellitus, if it is, then sugar levels will not normalize 6 weeks, even after 6 weeks postpartum. Alright, so you get that idea? Yes, we're clear on this? The diagnosis of GDM and the diagnosis of overt diabetes in pregnancy. We are clear with this? Any doubts? Okay, so we are clear with this. Now, another point that I want you to remember. Is, again could be a potential question, that when you have, let's say for example, you have a known diabetic, okay, like meaning that she is not yet pregnant, she's come for preconception counseling, okay. Now, please remember here that ideally all these known diabetics, pre-pregnancy diabetics, they are overt diabetes, okay. Whether it is type 1 or type 2 doesn't matter, they are overt diabetics, known diabetics, overt diabetes mellitus. They have come for pre-pregnancy counseling. One should definitely check their HbA1c. Checking HbA1c is very, very important. Why? Because the level of HbA1c is directly proportional to the risk of congenital malformations. Right, because overt diabetes mellitus is going to be associated with increased risk of congenital malformation. So, very, very important, we check the HbA1c and we also check the woman's disease status. Other than that, for the maternal health also, checking her disease status, whether she has pre-existent diabetic, pre-existent retinopathy, whether she has pre-existent nephropathy. Now, all those complications related to diabetes, the maternal health status also needs to be checked and optimized pre-pregnancy, right? So, what we need to do, we need to optimize the disease. Ideally, this is all ideally, we need to optimize the disease status pre-pregnancy, and please remember, very, very important point, that the HbA1c should ideally be less than 6.5% for good pregnancy outcome, because higher the HbA1c, more is the risk of congenital malformation. So, HbA1c should be brought in control. So, the question they can ask you is that they give you a scenario where a woman is overt diabetic and they tell you what is the most appropriate management strategy. The most appropriate management strategy is to control the disease status, control the blood sugar levels, ideally pre-pregnancy, and it is better ideally that these women should be on insulin. Okay, when they are trying to get pregnant, they should be switched over to insulin for better control, right? Should be on insulin for better control. Keep that in mind, right? Very, very important. So, they should be switched over to insulin in the periconceptional period. And she may be taking other drugs. If she is already diabetic, she may be taking ACE inhibitors maybe, or she may be also be hypertensive along with it. So maybe she may be taking certain drugs which are not to be used in pregnancy, like for example ACE inhibitors and angiotensin receptor blockers. So those drugs also need to be stopped. Right. So that kind of pre-pregnancy workup is needed for these patients, and this could be a potential question. All right. So clear on this now? We'll move ahead with the next question. All right. Now, next question. 35-year-old obese woman has been trying to conceive. Irregular menstrual cycles are there. Infertility is there obviously because cycles are irregular. So when you see irregular cycles, you're talking about anovulation. When you see irregular cycles, you're talking about anovulation. What have you marked for this question? She has no history of PID, ultrasound shows no uterine abnormalities, right? So, if it would have been a fibroid, it would have been picked up. Alcohol abuse, unlikely here now, right? Her day 3 hormone levels are FSH, LH, ratio is also mentioned 2.4. Testosterone is this is within normal limit range. And progesterone is also fine for day 3. Day 3 progesterone low. Progesterone elevates or higher levels of progesterone in the luteal phase. So all this is okay. The only concerning is LH-FSH ratio. Which of the following is the most likely cause of her infertility? This is a simple question. Anovulation history is there. Irregular menstrual cycle is there. For premature ovarian failure, context will be different. Context most likely is going to be that of persistent amenorrhea. Okay, here cycles are irregular. Why are you? Look at the most common cause, right? Look at the most common cause, right? LH-FSH ratio more than 2, right? So these are otherwise in normal range. FSH, LH values are otherwise in the normal range, okay? Testosterone levels are also in the normal range. What is pointing towards the diagnosis of PCOS in this particular patient is irregular menstrual cycles and abnormal LH-FSH ratio. However, I also know that according to the Rotterdam's criteria, you would need, you would need abnormal menstrual history, you would need some feature of hyperandrogenism, or you would need the ultrasound appearance of polycystic ovaries, right? So, you would need 2 out of 3 here. So here they are not mentioning anything about the polycystic ovaries, but even then when they ask you most likely cause of her infertility, then most likely best answer to choose is ovulatory dysfunction, not premature ovarian failure. Okay. So not premature ovarian failure, but ovulatory dysfunction. Clear? Now how do you diagnose premature ovarian failure? What will happen if ovaries are failing? If ovaries are failing, meaning ovaries are not, the number of follicles has declined, follicles are getting depleted at a very fast rate. That is what is happening in premature ovarian failure, just like that happens in menopause. But premature meaning it is happening earlier than expected in a woman. That is what premature means. Ovarian failure simply means that the ovarian follicles are depleting and they have gotten depleted. Like that happens in menopause. If it happens earlier than expected, then it is called as premature ovarian failure, right? AMH is going to fall, FSH is going to be high. Now this is not high FSH, normal FSH values, and generally FSH values you need to remember are between 5 to 20 MIU per ml. These are the normal ranges in reproductive age group women. Alright, so it is not going to be premature ovarian failure also. The answer is not premature ovarian failure. They have asked question on premature ovarian failure in INI-CET. So let me just give you important pointers regarding premature ovarian failure. Okay, so premature ovarian failure. First of all, the clinical context. Note the clinical context, okay. The clinical context, will that be of, maybe she has, also she wants to get pregnant, she's trying to get pregnant, that is her desire, that's another matter, but she will have amenorrhea, okay. She will have amenorrhea, and she will also have persistent hypogonadism. Now let me explain these terms to you. She will have symptoms of estrogen deficiency. She has amenorrhea because of estrogen deficiency or low levels of estrogen. However, estrogen levels tend to fluctuate a lot. So estrogen levels alone are not very reliable to make the diagnosis of premature ovarian failure. What is important is hypergonadotropic. Okay. So what is going to be important is serum FSH. So serum FSH values more than 25 to 40 international units per liter. More than 40 is the menopausal range. But more than 25 in this clinical context, I get concerned. So that is why this range is given. On 2 occasions, at least 1 month apart. Okay, this is going to make the diagnosis. Okay, serum AMH are also low, but they are not enough to make the diagnosis. Clear? Now the most common cause, remember, is idiopathic. Most of the time there is no cause identified. Most common cause is idiopathic. Then the second most common cause is autoimmunity. And then we also think about iatrogenic causes, which are more common. Iatrogenic causes meaning maybe some history of, chemotherapy, pelvic radiotherapy, chemotherapy, or surgical removal of the ovaries for some disease. Like that, iatrogenic. So idiopathic, autoimmunity, iatrogenic. These are the common causes, okay. Most common, then second most common, that you need to remember. Then others are fragile X premutations. Remember, fragile X premutation carriers also. And again, very, very important to remember that if a woman is less than 30 years of age and she is presenting with the clinical context, or in a woman who is less than 30 years of age and we have ended up diagnosing premature ovarian failure, we should also check for abnormalities involving the X chromosome. Right, like for example, there could be Turner mosaic, right? So there could be mosaicism. Turner mosaic could be there, deletions of particular sections of X chromosome or translocations like that. So there could be various types of abnormalities involving the X chromosome as well. Okay, and another important image-based pointer, which I think could be a potential question in your exams again, is this. Can you identify the image for me? I'll give you the clinical context. Woman had infertility and she was being worked up for infertility, and she was having history of scanty periods, or maybe they say history of amenorrhea, and we did an HSG. See, HSG is not used in fertility workup. Scanty periods, amenorrhea. Do fibroids typically cause amenorrhea and scanty periods? Fibroids do not typically cause amenorrhea or scanty periods, right? So look at the clinical context of what I am giving you, right? So we did an HSG as a part of infertility workup. Mark my words, HSG is not used for the diagnosis of this condition that I am asking you a question on. HSG may have been done as a part of infertility workup, checking for tubal patency, and this is what was found. Asherman syndrome, yes, and you can see the dye is also not coming out. The dye is also not coming out from the cornual ends, right? So this is showing, this HSG report is showing tubal blockage. This HSG is showing tubal blockage also, and it is also cornual tubal blockage also, and it is also showing filling defects inside the uterus. Right. So I know I could have given you maybe other clues. There could have been history of multiple DNCs. History of multiple DNCs could have been given. History of abortion followed by DNC could have been given, right? So this sort of history could have been given. And another important cause for Asherman syndrome, where there is typically cornual blockage. Can you guess for me? Can you answer? Another important cause of Asherman syndrome and common in our country, where typically there is the cornua of the uterine cavity is typically involved and cornual blockage typically involved. Very good. Genital tuberculosis. So yes, this could be pointing towards Asherman syndrome. The diagnosis here is Asherman syndrome, right? And there could be history suggestive of genital tuberculosis also mentioned in the question. So this is how you correlate. Okay, this is how you correlate. The image always has to be analyzed in terms of a clinical context, right? So the clinical context could be infertility workup patient, scanty periods, amenorrhea, ended up with an HSG showing this image. So this is Asherman syndrome, right? Now you want to confirm the diagnosis of Asherman syndrome, you're going to go for a hysteroscopy. You're going for a hysteroscopy, right? And this is the hysteroscopy image. Right. So in hysteroscopy, you're going to get the confirmation also. You can look for maybe some, if there is genital tuberculosis, there can be evidence of these white tubercles in the endometrial lining also. So that sort of evidence can be there. While we are doing a hysteroscopy, we can go for this adhesiolysis also, right? So hysteroscopy and adhesiolysis. Now treatment is hysteroscopic adhesiolysis. Hysteroscopic adhesiolysis. Right? Bilateral cornual block can be hydrosalpinx too. No, hydrosalpinx will be that the tubes are dilated and filled with fluid, isn't it? So this is distal tubal block. Okay, bilateral hydrosalpinx is, the hydrosalping will be because of distal tubal blockage. Okay. Now the tubal damage could have resulted because of genital tuberculosis, or the tubal damage could have resulted because of PID. Whatever be the reason for the tubal damage, but hydrosalpinx will be with bilateral cornual block. Okay, rightly saying this can also be described as moth-eaten appearance. However, not many filling defects are seen, but I don't have the typically moth-eaten appearance I haven't got, but yes, with Asherman syndrome, they do describe it as moth-eaten appearance as well. Moth-eaten appearance on HSG as well. All right, so remember these two images. All right, now moving on to the next question. Simple, straightforward question, not much of explaining to do. 26-year-old woman for routine gynae examination. Vaginal cytology is performed and following cells are seen. These cells predominant under which hormone? So these are the pink colored cells which are predominating with abundant of cytoplasm and a small pycnitic nucleus. What are these cells? These are superficial cells. Very good. So these are superficial cells, they predominate under the influence of estrogen. Yes, this is estrogen. Under the influence of estrogen, superficial cells predominate, right? Under the influence of progesterone, it is the intermediate cells that predominate, and when there is no hormone stimulus, then basal cells and parabasal cells predominate. Okay, right? Now, moving on, next question. What have you attempted? What have you answered for this question? History of PID and difficulty conceiving. Okay, history of PID, difficulty conceiving. So, infertility context, they are asking most appropriate treatment option for this couple. Most appropriate treatment option. HSG shows no dye leakage from a fallopian tube. Partner semen analysis is normal. So, this is tubal factor. Okay, blocked tubes, likely. Okay, we have HSG showing no dye leakage from fallopian tubes. You see, they are asking you most appropriate treatment option. Treatment option for this couple. So obviously, if there is tubal factor infertility, there is no ovulation induction, and no ovulation induction, IUI is out. Now you have to choose between IVF and laparoscopic tuboplasty. Now tuboplasty is tubal surgeries, that means repairing the tubal damage, and there are different types of tuboplasty surgeries have been described, okay. Now, I keep explaining to you that tuboplasty surgeries now are more or less a thing of the past. I am not saying that they have become obsolete, but in today's clinical context of, or how infertility is being managed these days, all right. The best outcome for women with tubal factor is with in vitro fertilization. All right, tuboplasty surgeries, that means repair of the tubal damage by removing the damaged part, resecting, anastomosing, and fimbrioplasties, a number of different things. All right, now those are generally not the first line. Okay, what happens is, maybe I can think of situations where tuboplasty surgeries can be attempted, like attempt at removing the tubal blockage. All of that can be attempted. Let's say, for example, there's a young woman. Okay, she is, otherwise there's no other factor of infertility. She's just a young woman. She wants to try natural conception, but she's also not willing for IVF, or cannot financially afford an IVF, or we tend to do it in the periphery, in setups where patient cannot afford or cannot even go to a center where IVF facilities can be there. So maybe then yes, we can go for tuboplasty surgeries, but in current scenarios, the utility of tuboplasty surgeries has decreased. So most appropriate treatment option, best treatment option for this couple is IVF. So answer is IVF, not laparoscopic tuboplasty. However, yes, before IVF, in this patient, the treatment option is IVF, but before IVF, we need to go for, what will you do for before IVF? Before IVF, what should be ensured? One part of workup which is left. One part of workup which is left, which we generally tend to do. She has come with HSG report. I want to confirm also. Right? So this is HSG is a screening test. So before IVF, she will need laparoscopic chromoperturbation. All right. So I can confirm the tubal patency also. I can look at the pelvis also. I can look at the extent of tubal damage. I can look at, maybe there is some endometriosis there. So a complete workup, right? And preferably this would be laparoscopy plus hysteroscopy. Preferably. Why? Because I want to have a complete assessment of the uterine cavity also. Right. So if I'm going for IVF, I would want to complete my workup first. Okay. So laparoscopic chromoperturbation is for confirmation of tubal factor, and preferably this is combined with lap plus histo. All right. As a that you are going to go, we don't do this, no, that we do laparoscopy first, then later on we decide, oh, we needed hysteroscopy also. So if the option of laparoscopy plus hysteroscopy is there, that we choose. Okay, lapro plus hystero preferably, so that we can do complete workup in one sitting only. Now, one time we are giving GA to patient, laparoscopy we are doing under GA. So in that sitting only we will do hysteroscopy also. So complete workup can be done before subjecting her to IVF. Okay, clear on this? Why answer is not laparoscopy tuboplasty? Now, next question. 68-year-old woman presents with 3 cm vulval lesion. Biopsy confirms invasive squamous cell cancer with depth of invasion 1.5 mm. So you see here, when the depth of invasion is more than 1 mm and size is more than or equal to 2 cm, anything, right? Then you have to go for the lymph node dissection also. Then we can't go for no lymph node dissection. Okay. Chemoradiation therapy alone is not the answer. That is for advanced stage. See, they basically, just remember this. When you have stage 1A, remember this, that is size is less than or equal to 2 cm and depth of stromal invasion, depth of stromal invasion is less than or equal to 1 mm, both are there, then only we go for wide local excision and we can avoid the lymph nodes, right? That is the only situation where we can avoid the lymph nodes. But when we have stage 1B, this is stage 1B. In this question, this is stage 1B. Okay, now the size is also more and the depth of invasion is also more, right? Then we have to go for wide local excision with bilateral inguinofemoral lymphadenopathy. Okay, since negative lymph nodes are there, we have to do sentinel lymph node biopsy. I am going to take that out also. Best answer is radical vulvectomy with bilateral inguinal lymphadenectomy. Kashyap, how will you know that the inguinal lymph nodes are negative, my dear? How will you know? You will have to take them out, isn't it? Now, when there is stage 1B, then you have to go for bilateral inguinofemoral lymphadenectomy. Okay. Obviously, if there is clinically enlarged inguinofemoral lymph nodes, then you are going to remove that also. Obviously, enlarged lymph nodes will definitely be removed. But with stage 1B, okay, when clearly it is more than 2 centimeter and depth of invasion is also more, then you need to remove the lymph nodes. Now, you are asking me when to do sentinel lymph nodes. You know, there are limited situations where sentinel lymph, there is role of sentinel lymph node also. There is role of sentinel lymph node dissection in vulval cancer. But sentinel lymph node dissection in vulval cancer, but there are limited situations. That means it has to be a unifocal tumor with less than 4 centimeter size, but the depth of invasion is less than 1 mm. Okay. So, there are limited situations where sentinel lymph node dissection is done. Ideally, you have to go for bilateral inguinofemoral lymphadenectomy, okay, and wide local excision is done. Now, wide local excision is done in the sense that while doing the wide local excision, while achieving the tumor margins, we may end up doing a radical vulvectomy. So, that is the best answer to choose in this question, not wide local excision with sentinel lymph node biopsy. Okay, clear on this? And now, you know, the role of sentinel lymph node dissections is being involved in endometrial cancer also these days, but I don't think that will be asked in your exam. Remember, yes, there is a role of sentinel lymph node dissection in vulval cancer patient, but it is only in limited situations. Okay. Now, moving on, next question. On examination of a 60-year-old female with prolapse, the leading edge is more than 1 centimeter above the level of hymen. Which stage of POPQ system does this finding correspond to? So, in POPQ system, remember that they can give you an image and ask you what is this system. How to use that system is very complicated. We don't expect undergraduate students to know that. So, don't worry about mugging that up. But yes, of course, you should know from the level of the hymen what is the staging. So, the leading edge of the prolapse is more than 1 centimeter above the level of hymen. So, if this is the level of the hymen, whatever the leading edge of prolapse is, okay, if it is, let's say they are saying within 1 centimeter, this is 1 centimeter above, this is 1 centimeter below, and this is more than 1 centimeter above, and this is normal. Let's say this is the normal position. This is the normal position. Okay, normal position is stage 0, no prolapse. But here now it is here above. So, I try to remember this one. I remember this one. Within 1 centimeter. Within 1 centimeter, I remember it is stage 2. Within 1 centimeter, remember stage 2. Above that is stage 1, that is above 1 centimeter above the level of the hymen. So, they are saying more than 1 centimeter above the level of the hymen, right. Stage 2 is going to be within 1 centimeter. So, stage 2 is within 1 centimeter of hymen. So, within 1 centimeter of hymen could be from the hymen 1 centimeter above, from the hymen 1 centimeter below. Stage 3 is more than 1 centimeter below the hymen, right. So, stage 3 would be here. This would be stage, this is stage 1, this would be stage 3. Okay, more than 1 centimeter beyond the level of the hymen. That would be stage 3. And stage 4 would be complete eversion. Complete eversion of the vagina. That is what we call as procedentia also. This will be just procedentia. This will be simply procedentia, will be labeled as stage 4. Okay, clear? So this was straightforward, mugging up, no explaining to do here. What about this question? Yes, there is a local ulcer, right? There is an ulcerated lesion on the cervix, right? This is a protruding mass from her vagina. Difficulty urinating. There is a 3rd degree uterine prolapse, ulcerated area on the prolapsed tissue. What is the appropriate management? So this is a decubitus ulcer. This is a decubitus ulcer, and very good. This ulcer is because of venous congestion, and management includes glycerin and acreflavin packing. Okay, and antiseptic can be given. So there's no as such contraindication. Sometimes along with glycerin, acreflavin packing, we alternate it with sometimes with betadine also, depending upon if there is infection, overlying infection in this or not. So mainly hygroscopic packing. So that is glycerin and acreflavin packing. So that is the answer. This was straightforward. You did not even had to, read the other options in the question. Next question. 65-year-old woman. Few question banks give friction also. No, it is not due to friction. No. Friction, if see, there is venous congestion, and because of venous congestion, this area is devoid of, there is not a good perfusion in the tissues, right? So when there is not good enough perfusion in the tissues, what is going to happen? If there is any, obviously with friction, what will happen is that areas will get, eroded, and then ischemic, and then, poor healing of the tissues. So it is primarily a venous congestion ulcer, primarily because of venous congestion, not because of friction. Friction alone is not contributing to this ulcer. Okay, keep that in mind. Otherwise, when we put it inside, it is going to recover. That the whole treatment is basically to put it inside, reposition inside, and resume the blood flows to the tissues, right? So that is the answer. Okay, that is the best answer. Next question. Straightforward question. This is how questions on ovarian malignancies or ovarian tumors are generally framed, clinical context, and ask you to identify the histology. So 65-year-old woman presents with dyspnea, cough, painful abdominal distension, right-sided solid adnexal mass. Tumor was removed, found to be benign. So a benign tumor, symptoms resolve after tumor. Yes, what is this? Right-sided, there is dyspnea, dry cough is pleural effusion. This abdominal distension, which is painful because it is too much of abdominal distension, that's ascites. And there is a solid adnexal mass, which is actually benign. It is ovarian fibroma, very good. And this is Meigs syndrome. This is Meigs syndrome. So that is your answer. Clear cut, you have answered. And like I said, that this is not malignant spread, this is reactive ascites, this is reactive pleural effusion. So once the mass is removed, this settles down. So this reactive ascites and this reactive pleural effusion, this is because of vascular endothelial growth factor, which is released from the tumor, and that is responsible for this reactive pleural effusion and reactive ascites. Okay. Next question. Which of the following is the most likely diagnosis in a woman who presents with heavy menstrual bleeding, pelvic discomfort, frequent urination, uterus is found to be irregularly enlarged? Straightforward question. In endometriosis, there is no uterus enlargement. If it is ovarian cyst by itself will not cause heavy menstrual bleeding, and they should mention ovarian cyst, right? And it is not PCOS. This is straightforward question. No need to explain this. This is leiomyoma. This is fibroid. irregularly enlarged uterus, heavy menstrual bleeding. Because the uterus is so enlarged and it has become bulky, it is also causing pelvic discomfort. And maybe there is a fibroid which is probably, you know, in the anterior aspect or lower uterine segment, and maybe that fibroid, because it's big enough in size, is putting pressure on the bladder and it is leading to urinary symptoms also. Right? So, all of the profile of the patient goes in favor of leiomyoma. Next question, match the following statements with the right option. Now, see, the trick of these questions is, when you have to match the column kind of questions, is that at least out of the 4 options, no, pick one that you for sure know, and most of the times you will know it. One you will know. If you don't know all, one you will know. Like for example, if we start with Chadwick sign, okay, if we start with Chadwick sign is bluish discoloration of the vaginal wall and bluish hue or discoloration, bluish hue of the cervix and bluish hue of the vaginal wall. That is Chadwick sign. So, one is going to match with C. So, I am anyways going to eliminate option A and D. And then you can look at the other options also. Goodle sign is softening of the cervix. So, then you mix and match what else you know. Then you mix and match what else you know. So, Goodle sign is for softening of the cervix. Chadwick sign is matching with this. Oceander sign is pulsations fell through the lateral vaginal fornices because of the increased uterine artery flow and dilated uterine artery, and Hagar's sign is because of softening of the isthmus. Okay. So, the trick to attempt these questions faster is eliminate 2 options and then what you are left with 2 and then match the remaining 2 options. Okay, that is how you will attempt such questions faster. Though eliminate karke karna, that will make you do these questions faster. Next question. All right, during routine visit, a pregnant woman says episodes of occasional tightening in front of her abdomen that are irregular and painless. They are painless. Some tightening in front of her abdomen. Uterus is non-tender, no cervical changes are noted. What is the most likely diagnosis? Straightforward question. Braxton Hicks. So, Braxton Hicks contractions, they keep happening throughout pregnancy. They are very low intensity. They are very low intensity. Low intensity 8 to 10 mmHg. That is why they are painless. That is why they are painless. Okay, that is why they are painless. Okay, please remember that uterine contractions start becoming palpable. Okay, they start becoming palpable once the threshold of 10 mmHg is reached, and they start becoming painful. Uterine contractions start becoming painful and capable of causing cervical dilatation at a threshold of 15 mmHg intensity. Okay, so these are very low intensity, these are Braxton Hicks, they happen throughout pregnancy. If there are no cervical changes, then this is not true labor pains. True labor pains will have progressive cervical dilatation and effacement, right? And abruption is not there. This is not fitting. So, no symptomatology, no bleeding, no pain, nothing. This is not abruption, right? Uterine inertia is weak contractions. Uterine inertia is intensity of contractions that over a period of time tends to remain low, less than 25 mmHg. So, by definition, this is uterine inertia. Okay. Show can be present, can be absent. Leaking can be present, can be absent. The most important sign, how do we diagnose true labor pain? The most important sign is progressive cervical dilatation and effacement. So, we will have to observe a woman over time. Okay. So, that is how we will diagnose true labor pains, and once there is cervical dilatation and effacement, we will start feeling on PV examination a bulging bag of membranes. So, better answer to choose is cervical dilatation and effacement, that is progressive, and second best answer to choose is bag of membranes, because we are able to feel a bulging bag of membranes only when the cervix is going to get dilated and effaced progressively over time. Okay, so keep that in mind. Okay, Now you are saying false contractions, Kashyap. These very same Baxton Hicks contraction, no, they also they start to increase in intensity, then frequency a little bit more, and they will go into, the woman will go into false pain. Many women will experience these false labor pains, but ultimately these very same contractions will evolve into true labor pains once they become capable of causing cervical dilatation and effacement. Okay, so that is the logic. Next question. Yes. Which of the following is a physiological cardiac change typically observed during pregnancy? Physiological cardiac change. You don't, if you want to attempt this question fast, you probably don't need to read the full question. Because if you start reading which of the following is a physiological cardiac change typically observed during pregnancy, the rest of the history that I have given you is just a profile. Okay, there's just a profile. So learn how to read fast. So one way to do that is read the first line and then read the last line, especially in long length questions. Is it even relevant to read the entire length of question? At times they trick you like this, okay. So which of the following is physiological? Decrease cardiac output? No, cardiac output increases. Increase in systemic vascular resistance leading to hypertension? Of course not. There is hypotension, BP falls in pregnancy, and that is because of decrease in systemic vascular resistance. So you know it is increased cardiac output that is happening because of increased heart rate and stroke volume, and heart rate is not decreased, right. So this is your answer, right. So you see how you will read such questions, okay. So sometimes, and this is an example of a situation where at times the stem of the question is immaterial, and you come to realize that because you read the last line first. So get into this habit of reading the last line of the question first when you have long stem questions, okay. Clear? Tell me one more question. When is the cardiac output maximum? When is the risk of heart failure maximum? Yes. This can be a question, it can be framed in a different language. They may ask you when is the cardiac output maximum, or they may tell you there is a woman with heart disease in pregnancy and when is her risk of going into heart failure maximum. So when is cardiac output maximum, when is heart failure maximum? Yes. Answer? Immediately postpartum. Very good. Immediately postpartum, immediately after delivery. That is your answer. Then intrapartum, then during delivery, and antepartum period. It is in the antepartum period, it is between 28 to 32 weeks. It is between 28 to 32 weeks. See, cardiac output slightly is lower at term. Cardiac output is slightly lower at term. Why? Because of the compression of inferior vena cava by the gravid uterus. That is why there is decrease in venous return, and that is why there is a decrease in cardiac output. So cardiac output is slightly lower at term as compared to, you know, between 28 to 32 weeks. At term it slightly falls down because of compression of inferior vena cava by the gravid uterus, and that is why we tell the woman to lie down in the left lateral position. Left lateral position is the best position, right. Left lateral position is the best position for the woman also, for the baby also. In left lateral position, woman maintains her cardiac output. In left lateral position, because cardiac output is maintained better, then the placental perfusion is also better. So it is best position both for the baby and for the mother also. Next question. Okay, next question is just an extension of this very question. Next question is again an extension of this very question. Primigravida, inner third trimester, dizziness and shortness of breath, especially when lying down on her back. So what is happening to her? Supine hypotension. Supine hypotension is happening to her. She feels better when she is on her left side. This is because of compression of the inferior vena cava. Okay, so inferior vena cava compression, decrease venous return, decrease cardiac output, therefore decrease in blood pressure as well. All right. Now the other important thing is that I can ask the similar question in a different clinical context also, right. So one clinical context was the previous question that we saw on cardiac output. Then another clinical context could be that a woman is having this supine hypotension like syndrome in the 3rd trimester. The other clinical context is that when we do a cesarean section, during a cesarean section, how do we maintain the position of the patient? Patient is supine, but we maintain a slight left lateral tilt. Okay, we have to maintain a slight left lateral tilt. That is what we prefer. So OT tables can be tilted, okay, but if OT table cannot be tilted, then wedge under the right hip, wedge under the right hip. So if I'm going to put a wedge under the right hip, slightly it is going to give the left lateral tilt, because I want to avoid blood pressure fluctuations during cesarean section, and I want to have placental perfusion maintained during cesarean section also. So these are the 2 reasons why during cesarean section the slight left lateral tilt is good. Okay, clear? Now, next question. Yes, which factor contributes significantly to the hypercoagulable state observed in pregnancy? Yes, significantly. One factor which is increased by about 50%, hypercoagulable state, significantly. Antithrombin 3 levels are lower, that's fine. But again, this is close. There are decreased levels of antithrombin 3, that is also correct. In fact, there is decreased levels of protein, there is decreased levels of protein S, not elevated. Okay. So remember, all clotting factors increase except factor 11 and 13. Okay, so factor 8 levels are also going to increase. There is, yes, decreased levels of antithrombin 3 also, but the main contributing factor is increase in clotting factors. And there is one typical clotting factor which increases by 50%, and that is fibrinogen. Increased levels of fibrinogen, they get elevated by 50% during pregnancy, right? So there is also APC resistance in pregnancy. Decreased levels of antithrombin 3 are also there. That is all correct. But yes, mainly increased levels of fibrinogen. Also remember, excite point for INI-CET I am giving you. If you check the APTT values, PT values, BT, CT, CRT values in a pregnant woman, okay, if you were to take the blood sample, check these values, they will be within normal range, they will be within normal limits, right? So it is a hypercoagulable state, yes, okay, that is true, right? But in the body, there is no spontaneous thrombosis happening. No, she is at high risk of thrombosis by virtue of this hypercoagulable state. All that is true, but in the body, a homeostasis between the coagulation system and the anticoagulation system, the coagulation system and the fibrinolytic system, that homeostasis is maintained. So when you look at their values of APTT, PT, BT, CT, CRT and everything, they are going to be within normal limits. Keep that in mind. And then the next question arises, is about prevention of deep venous thrombosis in pregnancy. So prevention of deep venous thrombosis in pregnancy, something that we will do routinely, something that we will also follow postpartum also, because fibrinogen levels, you see, these fibrinogen levels are elevated in pregnancy. They will remain elevated up to 2 weeks postpartum also. So even postpartum, this hypercoagulability persists till the coagulation factors are normalized. So prevention of DVT is important, and don't just jump to the drugs immediately. Don't jump to the drugs immediately. Puja, not leg elevation. Why leg elevation will prevent against thrombosis? Huh? Remember apart from hypercoagulability, remember the triad of thrombosis which you read in pathology, the basic triad: stasis, venous stasis. So you have elevated leg or leg straight or whatever, as long as there is stasis, there is risk of thrombosis. Turbulence flow, there's risk of thrombosis. So we have to look at the medical factors that contribute to thrombosis. You have a long list of medical factors that contribute to thrombosis, which you read in pathology. In pregnancy, what do? We advise the woman to maintain her hydration. Yes, varicose tries, Neha, that is what I was talking about. So you ask her to maintain her hydration. You ask her to maintain her ambulation. Okay, you tell her, and at every step of the way we tell her, we don't ask her. In pregnancy, there are very limited situations when a woman is advised absolute bed rest, and maybe only for antepartum hemorrhage or when she is bleeding, then that is when she will be on bed rest. Otherwise, bed rest is never a very good idea in pregnancy. So hydration, ambulation, right? Let's say, for example, after vaginal delivery, you have seen this, or after cesarean section, you have seen this, that patients are asked to move up and about, aren't they asked to move up and about, and early ambulation is encouraged, early ambulation, hydration, these are anyways methods of prevention of DVT. And pneumatic compression stockings, Supposing there is a patient, we have done a cesarean section and she is not able to, she is in too much pain, she is not able to, or there is a difficult cesarean section, she is not able to walk, then we can use pneumatic compression stockings also. And yes, if they ask you drug of choice, for prevention of DVT, okay, it is low molecular weight heparin. So when there is a woman, let's say, with multiple risk factors in pregnancy, right, she is obese also, maybe she has medical comorbidities, and then maybe she ended up with a cesarean section, now she is bedridden also. So there may be situations, or there is a prior history of DVT. Now you don't need to mug up this list, because they are not going to ask you the indications of low molecular weight heparin, but they want you to know that this is going to be the preferred drug of choice if there is a woman who has certain high risk factors, because of which we have started on her on prevention of DVT. The drug of choice is low molecular weight heparin, Pooja, not aspirin. Okay, for prevention of DVT, it is low molecular weight heparin, not unfractionated heparin, not warfarin. For prevention of DVT, even for treatment of deep venous thrombosis, it is low molecular weight heparin. Okay, keep that in mind. All right, clear on this? Next question. All right, what is the causative agent for this situation? Yellow, green, foul smelling vaginal discharge, painful urination, intense itching, vulva and vaginal walls appear inflamed. Yes, very good. This is straightforward question. Trichomonas vaginalis is the answer. Okay. So let me just take you through this. Everybody knows this. Nobody is taking up another option. So just go through this chart with me here. So they can give you this kind of questions, okay, that a woman comes with complaint of vaginal discharge, PS and PV you have to do first. If the cervix is healthy and the discharge is coming from the vagina, if you see curdy white discharge, intense itching is there, fungal pseudo-hyphae are seen, it is candida. If they mention greenish frothy discharge, strawberry cervix, like that, flagellated microorganisms, right, then we say this is trichomoniasis. And milky white, these are clue cells, milky white discharge, fishy odor, no itching, pH more than 4.5, clue cells, no WBCs, whiff test is positive, then this is bacterial vaginosis. So look at these boxes, these will help you in quick revision. Also make a note that the investigation of choice for these vaginitis is basically, when we talk about vaginitis, the investigation of choice is a simple wet smear. It will give us the information. It will show us fungal pseudo-hyphae, flagellated microorganism, right, or clue cells, and that can be seen on wet smear as well. So this is the first line investigation. If the discharge is coming out from the os, they may give you situation like this, or cervix is unhealthy, cervical erosion mentioned. So please remember that this is clinically cervicitis. Okay, this is clinically cervicitis, and do not forget that if I do a per speculum examination and I happen to look at an unhealthy cervix, or I happen to see a cervical discharge, or I happen to see any discharge, before doing a PV, take the sample. Please take whatever sample one has to take before doing a PV. Otherwise, you will do the PV, you will remove the discharge. What sample will you take? And it will get contaminated, right? So, PS, any sample that needs to be taken, take that. Then you do the PV examination, right? So, when we have clinically cervicitis, then gram stain can be helpful. Gram stain I have particularly mentioned. However, yes, when you look at chlamydia or gonorrhea, these are the two important causative agents of cervicitis. When you look at chlamydia and gonorrhea, clinically cervicitis, most common is chlamydia. Okay. If you look at the investigation of choice, it is nucleic acid amplification tests, that is correct. But sometimes we have to rely on gram stain, particularly in the peripheral healthcare centers and even in government hospitals and district hospitals, these nucleic acid amplification tests may not be available everywhere, and they are expensive point of care test. Okay, so even though they are investigation of choices, like they are better sensitivity and specificity as compared to a gram stain, but sometimes we may be only left with the option of gram stain, right? So if gram stain is showing no organism and WBC is present, it is chlamydia. And if gram stain is showing WBC is positive and gram negative intracellular diplococci, then the presumptive diagnosis is gonorrhea, and then we can treat with this treatment, right? So when you have chlamydia, it is doxycycline, azithromycin is also an alternative drug, and for gonorrhea, it is combination of ceftriaxone doxy and ceftriaxone azithro. So remember this chart, okay? Now, moving on, also keep in mind the NACO kits for syndromic treatment. Please remember here the NACO kits for syndromic treatment. When you have cervical discharge, you are treating the symptomatic partner also, because we are not syndromic treatment, meaning that we are treating for all the agents. So, this contains azithro and cefixime. It's a single day treatment, okay, and we are not confirming chlamydia or gonorrhea, but we are treating the syndrome of cervical discharge, similarly vaginal discharge. So, when we are doing a syndromic management, look at this vaginal discharge, it has secnidazole, fluconazole, and so secnidazole is going to cover for trichomoniasis and bacterial vaginosis, and fluconazole for candidiasis. So, it is going to cover the vaginitis organisms. So, vaginal discharge treated. Then you treat the symptomatic partner. And when you have lower abdominal pain, remember we treat that with kit 6, lower abdominal pain or PID. Please remember PID is mainly a clinical diagnosis, okay. So, PID will have, along with maybe some evidence of vaginitis or cervicitis, upper genital tract infection. So, minimum criteria you need adnexal or uterine or cervical motion tenderness. This minimum criteria you need to make the diagnosis of PID. And if that is the diagnosis, or a patient is presenting with lower abdominal pain, kit 6 is being used, and then in that situation we have to treat the partner with kit 1. Then we have to treat the partner with kit 1. Remember these extra pointers also. These kits are mainly discussed by your PSM and Derma faculty also, they discuss this, so I won't be going into too much detail with this.